Hi, it's Randy Wong. I'm a retina specialist in Northern Virginia, just outside of Washington, D.C. This is a vitrectomy, which nicely demonstrates a very obvious floater in this patient who has had a PVD. This patient is monocular. She does not see well out of her other eye, and she's had a floater for over 5 years. And as you can see, it is very disruptive to her vision, as you can see the very large shadow that is cast on her retina. And I think unlike some of the other videos, this is really self-explanatory. There's the optic nerve. And you can see the vitreous kind of swishing back and forth. And so therefore all floaters kind of have to float back and forth with eye movement. That silvery shadow in the upper right is just an air bubble. So the retina is the inside lining of the eye. It captures light, transmits it through the optic nerve to our brain to produce vision. In patients with opacities or floaters, the vitreous contains some elements which actually absorb light and cast shadows on the retina, as you can see here. And again, those little round bubbles are actually just bubbles of air that get mixed in during the operation almost every time. Now you can see the confluent vitreous off to the side, but the real culprit is this gigantic central spider that's moving across her macula, which gives her some really annoying and debilitating changes in her vision. What I like to do is go off to the side and move in a circular fashion around the eye. I don't necessarily go right after the opacity itself. As she has had a PVD, the opacity will actually come to my instruments. So it makes the removal of the vitreous very efficient both in time and with regard to the amount of vitreous I'm able to remove. There's a nice demonstration of where the macula is, which is what the area of the retina that gives you central vision, your best color perception. That's the only area of the retina that gives you 20/20 vision. So again, you can see as the shadows are cast over the macula, it must have been really annoying and disruptive to her central vision. The rest of her retina is very normal. I don't see any evidence of disease, holes, or tears. There's certainly no retinal detachment. What I want to do after I've removed most of the central vitreous is go around to the sides, inspect the retina to make sure it's healthy, and also remove as much easy vitreous or peripheral vitreous as I can. The idea of operating in this scenario is to significantly reduce the number of floaters without causing permanent damage. So I always have to gauge how aggressive I need to be in removing the peripheral or side vitreous. Once I'm done, and it doesn't demonstrate it here, I'll look for holes or tears by depression. I'll actually depress from the outside in. Well, I hope you enjoyed this short video. I'm Randy Wong. I'm a retina specialist in Northern Virginia. We'll see you next time. Thank you so much for watching. And always thank you very much to the Brooklyn Duo for letting me use their music in these videos. Take care. See you next time. Bye-bye.